This is part 2 of the newborn nutrition lecture covering chapter 19 in your text. We'll moving off of the benefits of breastfeeding and techniques and important health promotion pieces to breastfeeding. We're going to move into some of the complications of breastfeeding. Your complications of breastfeeding oftentimes begin with, again, nipple breakdown, and the intact skin or the skin integrity is no longer present, which can then subsequently lead to a mastitis. Signs and symptoms of a mastitis are pain. That's usually the first sign for on the part of the mom, complaining of pain, reddened area on the breast, fever, malaise, flu-like symptoms. When we see mastitis or symptoms of mastitis, she needs to be in touch with her obstetrician or primary care physician to receive adequate treatment. She will breastfeed through her mastitis. It's an unusual circumstance where moms question, well, if I have an infection, is it safe for my baby to eat? And the infection is in the tissue of her breast, not in her breast milk. So she should, and it's actually therapeutic to breastfeed because that will help with the clogged ducts. So mastitis can form from tissue injury at the nipple, where it's now a portal of entry, or it can happen because we have pooling occurring in the milk glands deep in the breast. Usually due to improper emptying. So that's one of the reasons or rationales why we want to see moms using a variation or a variety of positions and holds, because we want that breast to empty from all angles of the breast. So if mom's using the same position repetitively, it actually increases her chances of having a mastitis. So prevention would be to have frequent position changes. Prevention of nipple breakdown we've already talked about in part 1, and that is proper positioning with a good latch. But positioning is key. Engorgement, it can be a complication of breastfeeding. Women who don't breastfeed will also experience engorgement, but in time, the body will not have received those messages to make milk, and she will subsequently dry up. She won't, we use the word dry up, but it's actually, she just simply won't make high volumes of milk. Breastfeeding women certainly will encounter times of engorgement. Engorgement is uncomfortable for the woman, and it can make it difficult for the baby to latch on because the breast itself becomes so firm and the nipple is no longer soft and pliable. So in the case of engorgement, what we can teach moms is to manually express, to soften the nipple a little bit. She can use warm soaks to the breast, like a warm face cloth, and that will help the let down and the milk escape the breast. The obvious is let's get the baby to breast so we can relieve the engorgement. Poor milk production is very rare. Less than 1% of women will have inadequate breast milk supply. But we'll see that typically in the baby and all those things that we were watching closely from a few slides back. Urinary output, weights, activity level of the baby, jaundice. So when we see those things, those can be indicators that she's not making adequate milk and the baby would require some supplementation. Breast milk hyperbilirubinemia is a physiological hyperbilirubinemia, whereas it's not like the pathological form where it's actually underlying blood hemolytic disease, where we have either a Coombs factor or an ABO incompatibility setup. So for this type of bilirubin, it's basically that the baby is experiencing higher levels of bilirubin due to the breast milk. When we see breast milk hyperbilirubinemia, the difference between a pathological hyperbilirubinemia is that they will have increased levels and they'll present with a jaundice appearance, but it's not the pathological levels of hyperbilirubinemia that could create kernicterus or disease within the brain. So we watch it closely to rule out pathological hyperbilirubinemia, and then counsel the mother with and the family with just surveillance to see that it resolves itself over time. And then the anxiety and the psychosocial factors that can come along with breastfeeding. Again, in the American, the culture of this country, breastfeeding was at an all-time low in the 80s and 90s, late 70s, throughout the decade of the 80s, and it took well into the 90s before the message and the public announcements that were promoting the benefits of breastfeeding. Basically what was rendered because of that is that we had a series of generations of moms who didn't breastfeed their babies because they weren't aware, because there wasn't awareness brought to it. And these trends came from the industrialization era and the war era, where men went to war and women were left to work the factories and have babies. And therefore the formula companies designed, milk that was safe and fit for a newborn. And then there were the sociological trends of that, the wealthy could use these bottles and have their nannies and their help feed their baby, and then they didn't have to get up at night. So then, it became trendy to use formula, and lo and behold, breastfeeding became an art of the past. So the last 25 years, we've had our work cut out for us, those of us who work in maternal child health, to raise awareness of the benefits of breastfeeding and then offer support to 2 generations now of women who didn't have support at home when they went home, because their mothers and grandmothers and their aunts and their friends perhaps were never breastfeeding their babies. And we know that we have a short window, 48 to 96 hours, to support women who breastfeed in an inpatient setting, and then they're going home. And that can provoke a lot of anxiety in parents, and certainly contributes to some psychosocial factors where women can feel isolated, alone, unsupported. So we take that into consideration as a complication of breastfeeding. We do know this: the more women that have breastfed surrounding a new breastfeeding mom increases the likelihood that she will remain committed to her breastfeeding. Women who leave our hospitals, leave our healthcare facilities without that level of support around them, there's an increased likelihood that they will discontinue their breastfeeding in the next 2 to 4 weeks. So definitely a lot of angst without that support. Don't want to leave this conversation without addressing formula feeding. Formula feeding is appropriate in cases where women cannot breastfeed for those reasons we discussed earlier, or for babies who need supplementation due to their own health issues, or for women who have identified themselves as somebody who doesn't feel comfortable breastfeeding, and that is an appropriate decision. Women must know what they feel comfortable doing. That is key to successful bonding and successful segue into parenthood. So formula feeding, we're referring to these commercially prepared formulas, and they come in typically a variety of 3 ways. That is, there's a powder form that would be mixed and diluted, a condensed form that would be mixed and diluted, or a ready-made form that there's no cooking, no baking for this one. You just crack it open and you can use it. What is super important is that parents are well instructed on how to use these 3 different forms. They're all very different. And even then how to store it once they've prepared it. So the labels are pretty clear, and I think that our pharmaceuticals who produce these commercial preparations have gotten savvy on how to write directions that are easy to read, because you can imagine the outcome if they're not preparing these formulas properly, the parents at home, the caregivers at home. So that's a really high important on our checklist of discharge teaching to make sure that parents understand how to formula feed their baby. They require the same volume we talked about earlier, the 150 to 200 per kilogram per day. And then the rule of thumb for a full-term newborn is that they would be taking approximately, and this can vary, but approximately on the average for a baby who's born in the 7 to 8 pound range, 15 mLs, and that would happen about every 3 to 4 hours in that first 24-hour window. It gives us a place to start. So in the nursery setting, in the maternal child setting, we know if we have a full-term infant that's going to be fed, we certainly wouldn't be giving them 30 mLs on that first day of life. That would be a lot. And if they take 5, they take 5, but 15 would be what we can expect them to take. And then from that point, feedings increase. The rule of thumb, according to the American Academy of Pediatrics, is that when we talk about, well, how much more do you give a baby? That you really should be holding steady over 3 to 5 days. So if we start at 15 mLs, and if they were going to go up in that 3 to 5 day range, it would be increasing it by approximately 10%. And that's just a rough estimate as to how we advance. As far as formula feeding techniques are concerned, the list is not as long because the learning curve isn't so steep. If you hold a bottle upside down, it will drip, typically. So, whereas mums don't if we hold them upside down, right? If it's placed in the mouth properly, it should be placed at the back of the mouth, and the nipples do come in a variety of shapes and sizes. So, newborn nipples versus a 3+ month nipple, all that indicates is the size of the opening at the tip of the nipple. So, we typically use for the newborn size. And then the shape would be a straight nipple, or perhaps it's an orthodontic nipple. There are a couple of different shapes of nipples out there. When it comes to nipples, and there's a lot of debate, like which is the best nipple? Well, babies are born with a reflex to suck. So therefore, pretty much anything you put in a baby's mouth, they will try and suck on. The only time that the nipple is adamant, we must look at what kind of a nipple is used, is in the event of a cleft palate or cleft lip. In those cases, those infants would require a special Knepel or Haberman's feeding system. And there's no other option. That is the only option. When we talk about the healthy full-term newborn, it's usually oftentimes what the parent decides to go with and what they feel works best for their baby. And you would find 100 different answers if we asked 100 different sets of parents on how they landed on which nipple to use with their infants. The typical position would be a semi-Fowler's position for feeding a newborn. So it's not straight up, right? That would be a high. It's not laying flat, which would increase their likelihood that they would choke. And as far as burping is concerned, in the first 4 to 6 weeks, burping is encouraged at every ½ ounce. And then after the 6-week period, it would be encouraged every ounce. And once the baby is sitting up and moving more, it's basically on demand. As you see, the baby would need burping. But in that neonatal period, we tend to burp approximately every ½ ounce. So nursing care surrounding newborn nutrition, education, and assessment, those are the most important, as we leave this lecture, this discussion, the most important things when it comes to the topic of newborn nutrition that a nurse brings to their client, brings to their patient, is the ability to assess what the patient knows about how they're feeding their baby, assess how those feedings are going. So for the breastfeeding baby, it would be measuring output, measuring weight, tracking weight, but also assessing her nipples and how she feeds her baby. For the formula feeding baby, it would be watching the parents, assessing how they prepare the formula, offer the formula, burp the baby, those kinds of things. And then providing the education that's necessary for those parents to adequately provide nutrition for their newborn. That completes our discussion on Chapter 19 on newborn nutrition. Have a great day.